Thanks, Praveen.
Thank you so much for the invite. Actually, this talk was to be given in Barcelona, but somehow I could not go there, and because of some local meetings, I think we will complete your Barcelona trip here. Shall I start?
Yeah. Why don't you get started, Praveen?
Okay. Good afternoon, everyone. We talk a lot about the timing of surgery, natural recovery, shoulder issues, and also a lot about hand in birth brachial plexus palsy, but we don't often talk about restoration of elbow extension in birth palsy, especially as a secondary procedure. We know that when we are doing a nerve reconstruction, we try to put something for the elbow extension, but secondary procedures to restore elbow extensions are quite uncommon. So many times it appears, yeah, we know the priorities, elbow flexion, shoulder, hand. So where does this elbow extension stand, and is it really that important? And this type of appearance in a child actually tells us how important the triceps is. So the child tries to lift the shoulder up, and if the triceps is not there, the hand falls back at the elbow and child is not able to reach for any overhead activities for using the hand. So yes, restoration of elbow extension is important in patients who have good hand function. Because if the hand function is good and the triceps is not there, the patient would not be able to do any of the overhead activities and would not be able to reach out for things. Hence, the function of the hand would be dramatically reduced. Another video which shows that if the child does not have elbow extension, child would actually move on to the object rather than extending the elbow and going and picking up the object. So again, the emphasis is if the child has good hand function, then there is an indication for improving the elbow extensions to improve the outreach and to improve the overhead activities. Now, to understand it better, if we see the working space of the hand, that is where all the hand can reach, would be basically determined by how the shoulder is working and how the elbow is extending. If the elbow extension is not there, all these overhead activities, outreaching activities would suffer. So if elbow extension is absent, there would be a drastic shrinkage of working space of the hand. So the main indication for restoring elbow extension is in patients who have good hand function. Surprisingly, the literature related to restoration of elbow extension is very limited. So you could find just one paper over there, the brachioradialis transposition in birth palsy. The other papers are about reconstruction of elbow extension in adult brachial plexus injuries, though the principles may remain the same. Now, restoration of elbow extension can be done by these two conventional techniques, which have been used in past for various other conditions like tetraplegia. Deltoid to triceps, which was described by Moberg for tetraplegic patients to restore elbow extension. And later on, lower trapezius to triceps described by Bartelli in adult brachial plexus injuries. We have done 7 and 9 cases of each one of them, and I will show what we have learned from them. The deltoid to triceps, based on the original concepts of Moberg, the same principle, but we should make sure that the deltoid is functioning quite well and it is of grade 4 power. The posterior third of the deltoid extended with fasciolata and connected to the triceps, quite a standard operation. And this is the kind of result we can get. So this patient, we see the deltoid bulge is good, but he is not able to do shoulder abduction because he fears that the elbow will fall down into flexion. And this was incidentally the first case and also the oldest in the series. This is 2 years post-surgery. So this patient was 24 years at the time of surgery, and he expressed that his function is very, very much better after operation. He is able to reach out for things, do a lot of activities. And one thing which he specifically says is when he was driving a car, he is able to push onto the gear and he is able to drive the car much comfortably. So this again tells us that not only the appearance, overall reach is improved, but the function in day-to-day activity is also much better if the elbow extension and triceps power is restored. Another example, a 7-year-old girl, and after deltoid to triceps, to this post-op stage where she is able to very comfortably raise up the hand and would definitely have a much better overhead activities. When we evaluated these patients, we found that 5 of them had grade 3 triceps function. That means they are able to maintain their elbow in extension in abducted position. One patient, unfortunately, he had a rupture of this fasciolata at 6 months post-op. So that means we need to be careful in these patients and not to let them go totally free till at least 6 to 8 months. When we checked these patients, we found that not only the elbow extension is improved, but their shoulder abduction also is improved because they feel much more secure while doing a shoulder abduction now. But the problem is many of these birth palsy patients do not have a good deltoid function also. If the deltoid is not good, obviously it cannot be used for transfer. So such patients, we started using the lower trapezius to triceps, which was described by Bertelli for reconstruction in adult brachial plexus injuries, and he reported quite good results with that. This is one of the examples, the child having 0 triceps function. The operation is quite an extensive one where you take the lower trapezius with the paravertebral fascia, which could directly reach to the triceps in such a way. If this fascia is weak, we often augment it with the tensor fasciolata. We did 7 cases of this. All the patients recovered grade 2 power. They appeared that they are able to use the hand better in all the activities, but they were not able to do overhead abduction. You see, this patient is able to do an active elbow extension quite comfortably. He told that he is able to reach out for objects much better. But if we do a shoulder abduction, then we see that against gravity, he is not able to go up. So it is only about grade 2 recovery of the triceps, what we got from lower trapezius to triceps. Then we had a patient, which again is quite a common combination in patients who present late. So this patient had weak abduction and weak triceps. So we wanted to reconstruct both of them at same time. We planned for upper trapezius to deltoid and lower trapezius to triceps. So when we were evaluating these photographs, we thought that the lower trapezius is going to triceps and upper trapezius is going to the deltoid. And we thought, why not let this upper trapezius itself go to the triceps? Incidentally, in the next 2 weeks itself, we got these 2 children who required restoration of elbow extension and their deltoid function was weak. So we planned for this upper trapezius to triceps transfer in both of them. And after discussing with parents, we agreed to do this. This is the upper trapezius, the scheme of the operation. The upper trapezius elevated with the periosteum there so that we have a good amount of tissue to suture the fasciolata. And it goes down and attached to the triceps. We can note that the transfer goes above the level of the shoulder joint. So that means it could act as an abductor at the shoulder also, as well as an extensor at the elbow. Operative steps, the trapezius has been elevated there, extended with fasciolata graft, and it is attached to elbow triceps while keeping the elbow in full extension. So when we are adjusting the tension, we keep the shoulder 90 degrees abducted and elbow fully expanded. After putting 2 sutures, we confirm that the elbow is falling back to 90 degrees of flexion without tearing off, because we don't want to make this transfer very tight. And when we evaluated these patients, which were 9 patients, 5 of them girls and 4 boys, all of them were quite happy with the outcome. This is the first video what I showed in the beginning of the talk. The same child at 1 year post-op, we can see she is able to maintain that extended position of the elbow. She is even taking a weight and lifting the hand up like this. And she looked quite comfortable in doing all the activities. And this is again, she is holding a weight in that, and she is able to do an extension of the elbow and maintain it against gravity that amounts to grade 3+ elbow extension. So this is the improvement she got. Initially, she would even struggle to do shoulder abduction because she feels that the hand will fall down. Another example, this child, again, he is able to go into abduction and hold the elbow in extension, indicating that it is a grade 3+ power of elbow extension, which is achieved. And here we can note that not only he is able to extend the elbow in horizontal plane, but vertically also he is going up. That indicates that the grade 3+ power is achieved. Another example, a little bit grown-up girl. She was in 10th standard when we operated, and she also tells that her reach for the objects is improved. Now she does not have to go to the object, but she can reach out with the extended elbow. The interesting thing we observed is all these patients had elbow extension power of grade 3, as opposed to what we achieved by lower trapezius to triceps. These patients were able to maintain their arm in extension while shoulder is abducted. So we find that this is working better than the lower trapezius in this patient population. Seeing good results with this operation, we have started often combining it with the shoulder operations also. So this patient, we see that she had limitation of shoulder abduction also, and her triceps power also was weak. We again confirmed that the elbow extension splint also didn't improve anything. So she had a lot of contracture at the shoulder. She underwent shoulder release plus upper trapezius to triceps transfer. And this is the outcome at 9 months. You can see she is able to do a good shoulder abduction and maintain the elbow in extension in this abducted position of the shoulder. And this is the kind of improvement we get from the pre-op to post-op at 2 years post-surgery. Now, it becomes quite clear that this operation is quite useful for this patient. Then we started learning from the patients themselves that what functions improve. So they themselves express the driving, pushing things, getting out of the bed, removing the bed sheet, reaching out for objects, dressing themselves, and bathing. All these activities improve. Many times we didn't realize that when we are bathing and cleaning our opposite arm, we do require elbow extension to do those activities. And all the patients express that their overall comfort in day-to-day activities has improved a lot. And what good it is doing to patients, we have more learned from the patients themselves, because they come and tell that this is the function which has improved after the operation. So I think it is quite a good reconstruction to do. So all the patients who have good hand function are a perfect candidate to restore elbow extension once they have completed the stage for the shoulder. And often this elbow extension restoration operation can be combined with the shoulder surgery also. And while driving a cycle, many times we feel just if we are grabbing, that is enough. But if the elbow extension is restored, they are not just grabbing, they are supporting themselves and the bicycle while driving. And all the patients feel quite happy with this operation. Thank you so much.
Thank you, Paveen. That was very interesting. Let me see what we have on the chat. We have a question about the post-op rehabilitation. This looks like a very long fascia lata graft. And how do you balance the idea that it takes a long time for that to heal, but it also tends to form adhesions because it's a long distance?
Yeah. So what we do is actually this the concern about the long fascia and the strength of that is always there. So what we do is we immobilize the patients in 90 degrees of shoulder abduction. And as I told, when we are adjusting the tension is adjusted in such a way that the elbow is fully extended, the shoulder is abducted 90 degrees. But after suturing, we should be able to do a 90 degrees of elbow flexion. So post-operatively, patient is kept on a shoulder abduction splint, but from the day 2 itself, they are asked to move the elbow till 90 degrees of flexion, actively, passively, or assisted active passive. So
From
we
day
teach
2,
the
you said.
parents. Yeah, so day
From the
2.
second day after
Second
surgery.
day. So
Yeah.
we teach parents to slowly start bending the elbow actively and passively extending it. So children start doing the movement of the elbow right from day 2. So that is to mainly prevent the adhesion of the long fascial graft. The abduction splint is maintained for 4 weeks. At 4 weeks, we remove the abduction splint and then start shoulder abduction and elbow flexion. Elbow flexion is not allowed beyond 90 degrees till 2 months. So adhesion is prevented by early mobilization.
And then when you are, so if you're getting 90 degrees with the shoulder and abduction, and that shoulder comes down, you're
Yeah.
going to have less elbow just because of the routing. Has that been an issue for you? And when do you start? Yeah, so you have to coordinate where the elbow is and where the shoulder is at the same time. So could you clarify that a little bit?
Yeah. So when the shoulder is abducted, actually the transfer is a little more relaxed. So when the shoulder comes
Right.
down, the transfer is a little more tighter. But if we are able to maintain this 90 degrees flexion in shoulder abduction, then once the hand comes down, then children don't have difficulty in getting that 90 degrees flexion. But they take almost 3 months to reach to the mouth. And passive stretching is started after 2 months. But usually at 3 months, they are able to reach mouth, and that is the final goal of not losing any flexion.
Yes. Are there, well, you mentioned hand function. Do you have any consideration for children who have maybe not perfect elbow flexion? Are those not candidates for this type of an operation?
Yeah, true. If the elbow flexion is weak, we must not do, because the transfer could become much stronger than the weak elbow flexion. True. So I think that would be a prerequisite for doing this transfer. So elbow flexion should be at least grade 4.
Yeah, I mean, this is a very exciting results that you're showing. There were some questions about when do you do both lower trapezius and upper trapezius, and for well, for both, as you mentioned, or when do you do just one?
Yeah, actually, I put the photograph. So 2 patients we did combined, upper trapezius to deltoid and lower trapezius to triceps. But after that, we realized that the upper trapezius itself could be put to triceps to get both the effects. And our results with this combined thing is quite nice. So now we don't do combined for the upper trapezius to deltoid and lower trapezius to triceps. So if we are requiring to augment shoulder abduction and elbow extension, we would do upper trapezius to triceps, which addresses both.
And no lower trapezius?
No lower trapezius.
Yeah. Have you seen issues with scapular motion following this surgery, meaning more winging, less winging, more of a putty sign, less of a putty sign? Has there been a change?
Yeah, whenever we have used the lower trapezius, actually we felt that there was change in the increase in the scapula winging. And after upper trapezius transfer also, the scapula winging, I think it becomes more. Though parents have not complained about that, but I observe that it is a little bit more. I think because it gives some amount of more abduction contracture, leading to mobilization of the scapula. But fortunately, parents have not complained till now.
Yeah. If the patient had a spinal accessory to suprascapular nerve transfer, does that, I know that the upper trap is still innervated, but your lower trap is denervated. Is that a contraindication or relative contraindication? That's something to consider.
Yeah. Actually, in birth palsy patients, we have till now never used the trapezius spinal accessory if it has been used. But in adult palsy, we have used contralateral lower trapezius for elbow extension. And that works quite okay. So it would work in a birth palsy also, but somehow till now we have not required to do. So if spinal accessory has been used and the lower trapezius is paralyzed, we can do the upper trapezius to triceps. That is one option. But many times in children where we have done a spinal accessory to suprascapular transfer, we could be a little bit hesitant about disturbing our transfer. So we could go to the opposite trapezius and do a contralateral trapezius extended with fasciolata for elbow extension. It would work quite okay.
Yeah. And you find that the contralateral is on par with ipsilateral lower trap, because you showed
No,
results of the ipsilateral lower trap.
Yes.
So I imagine that the
training is more
contralateral is
difficult.
probably going to be, yeah.
Training is more difficult for the contralateral one. So we have done it for adults only till now, no child. But all these adults find very difficult to learn the new movement. And since they have to initially contract the contralateral limb, they take almost 4, 5, 6 months to understand, okay, this is the movement, what they have to do. I think training would be much difficult if we are taking the contralateral one.
Yeah. So let me see, go back to the chat here. Have you tried both for elbow with fasciolata graft for improving the strength? I don't know what that means. Let's see, the other question is, do you see subluxation of the upper trapezius anteriorly or posteriorly over the acromion? Meaning, does the upper trapezius slip the mountain?
Yeah.
Kind of like an extensor tendon.
That is a very good point. The upper trapezius actually would not subluxate anteriorly, but it can subluxate posteriorly. So when we are making a tunnel for it to go to triceps, we should make sure that we don't deglove the skin too much. So normally when you are doing a conventional trapezius to deltoid transfer, we raise the anterior and posterior flaps. So here we don't raise the posterior flap too much, because if we raise the posterior flap too much, then our graft goes much posteriorly and it may not act much at the shoulder. Yeah, it does sublux on the posterior side, never on the anterior, but posteriorly it will sublux. And one way to prevent that or avoid it to sublux too much is to have the dissection of the posterior flap less and let it be a little bit more on the superior aspect than it falling down. Yeah, but
so it's interesting. You're using basically the skin as your.
It will not sublux that much that it could prevent the shoulder abduction.
Yeah. Well, you're using the self as your pulley, is what you're saying. The septate.
It does not act like a pulley, but it stays on top. It is not acting like a pulley.
Yeah. Another question we had is, would you augment tendon transfer for external rotation at the same time?
Yeah, actually, the augmentation of external rotation.
Or how you would do that?
Yeah. So this transfer, by the anatomy of the transfer itself, it actually looks like it is going to give some external rotation also. You know, it is going from the posterior aspect and going in the same direction. So it could improve the external rotation also, provided passive external rotation is present. So it is not really meant for, but we observed that whenever we have done this trapezius to triceps transfer, children took little bit more time to get into internal rotation. That means the transfer is actually acting like an external rotation force also. Having said that, if the patient does not have passive external rotation, I think it is better to first correct the passive external rotation by doing an osteotomy procedures and then do the elbow extension reconstruction later. Because one of the things is if the limb is much internally rotated, the triceps has to work harder when the person is lifting the shoulder up. But if the limb is in external rotation, the triceps power is a little bit negated and supported by the gravity itself.
Sure, that's an excellent point. I think that's very true. Any other questions from the audience or our esteemed panel?
It's great. That's great talk, Praveen. It's really thought provoking, and at the conference in Barcelona we were talking about before, the Bassam presented the trapezius transfer, but the results you're getting with both shoulder. And one thing I think is really interesting is that some of those early photos you showed before your pure trapezius, pure triceps reconstructions were in fact improving shoulder abduction as well, without specifically routing it over the deltoid, which is interesting. I don't. There's going to be some mechanics in that, I guess. Dan, is that right? That it's got to be something about the kinematics of that transfer that improves the shoulder.
Yeah.
Even without the specific upper trapezius.
Yeah, even the patients where the deltoid is put to triceps, their abduction also improved, but there is nothing coming from top. So what I was thinking is maybe these patients have a kind of apprehension that whenever their hand is lifting, it is going to fall down.
Yeah, I agree.
Once that apprehension is corrected, they straight go up.
Yeah, I think there's a lot of apprehension to hitting yourself on the head.
Yeah.
Well, there should be.
Yeah. No one likes to smack themselves on the head.
Yeah.
I think it's also, what's interesting, Paveen, so is that a lot of times if you have these 7-8 avulsions, these kids will not recover triceps function. And it's very difficult sometimes particularly if you have very little function in the arm, if you have one of these global injuries, you really want to get triceps function so that you can allow your gracilis transfers, your free gracilis transfers to work. Because without triceps, it really doesn't work in the same way. And so I'm wondering if this is something that we can lean on in that setting to help us recover more arm function, particularly in the setting of doing a shoulder fusion. Because oftentimes, particularly in an adult, for example, you'll do, or in a traumatic child, it's not possible to reconstruct shoulder function, and we'll often have to do a fusion just to get better arm and shoulder control. And whether or not this would be a good option for that, and I'm considering whether or not limiting control of the shoulder by taking the trapezius would be a good thing or a bad thing. But I think it would make the triceps even function better, because you'd take away one more joint. Does that make sense? Yeah,
but I am actually quite concerned about fusion of shoulder in children.
Yeah, as am I. It's certainly a last resort.
Yeah.
But I think that point though, Dan, that if you stabilize the proximal joint, some of those kids who have got the very bad injuries, they've got a very unstable glenohumeral joint anterior and posteriorly, so they can't really use that as a fulcrum to.
Yeah. We have a few of these late presenting. They're 3 years out from injury, and they show up with a global injury from young trauma, and there's other than a free gracilis, there's not much you can offer. And I think all the surgeries that we've done to date, I mean, we tried this sort of Saha thing with the upper trap and the lower trap and the levator, and that was kind of a disaster in kids, as Bassam will tell you, and we can tell you. Yeah, I mean, a shoulder fusion in that setting has actually helped us to be able to reconstruct more elbow and also more distal function with a free gracilis. But what's been limiting us is the triceps, because we have to burn a gracilis to get triceps function, and then we only have one left for elbow flexion, and it doesn't allow us to get more distal function. So this may be an option. I
Yeah.
don't know what that would do to the shoulder kinematics taking the trapezius, since that you're relying on scapular motions to get whatever
Yeah.
you're going to
I
have.
think traumatic plexus palsy in children causes really global instability of the shoulder. Maybe that is a good indication for fusion, but birth palsy children are not so much unstable. So you are true. All the children with the traumatic brachial plexus, their shoulders are really unstable in all the directions. For them, it would be good to fuse it, and maybe we can transfer the trapezius to the triceps and then go on to the hand.
So I think
Yeah,
we probably
yeah.
should move on. Praveen, thank you very much. I know you've got
Thank you.
another webinar to jump into, so we really appreciate you coming along this afternoon or this evening or whenever it is.